So hi everyone, welcome to the second episode in the Fresh Air Talks with the Lung Path guys, with myself, Matt Cicchini, and you can follow me on Twitter at PathMatt, and my colleague and mentor, Dr. Sanjay Mukhopadhyay, who you can follow on Twitter at SM Lung Path Guy. So today we're going to go over some thymic lesions with some focus on thymomas, and we're going to start with a case here by Sanjay. Take it away.
Thanks, Matt. So I was, thinking as I was looking at these cases that I find that once a thymic lesion is resected, it's relatively like half the battle is already over. Like you,
Yeah,
the pressure is off.
yeah,
You don't have to tell if it's a lymphoma, hopefully, most
yeah,
of the time. And thymic carcinoma is pretty easy because it's so invasive on a resection. I don't even
yeah,
think we get that many resections of
yeah,
thymic carcinoma. So it really almost certainly is a thymoma at that point. A
yeah,
thymoma, thymic hyperplasia. It gets a little bit easier. So I feel
yeah.
like once the thing is resected, the stakes are a little bit lower and it's easier to do. So
Yeah,
I'm
the
going to
core
just run through
Yeah,
a
the core
few.
needle biopsies are really the challenge, I find in these.
Exactly. Yeah. I find that hard. Don't you, Matt? Like the core needle biopsy is harder than the resection specimen.
And I try to, when I'm looking at a lot of the resection specimens, imagine if what would like imagine this in a core, right? So like zoom down, and if I only had this area, right, to kind of train my eye to help when I'm dealing with these challenging core needle biopsies.
Yeah. Yeah. That's a great exercise to do mentally. I
Yeah.
think this is a obvious mass here, resected
Hmm.
um, anterior mediastinal lesion. And one thing, Matt, like taking from our previous conversation that I find odd about this case is it really doesn't have any fibrous bands at, at low magnification. So it doesn't read the textbook exactly.
Yeah.
But it does have some useful features. First of all, it's just a huge epithelial proliferation. That by itself takes it out of the realm of thymic hyperplasia or normal thymus.
Yeah.
It's just too much, and I think that's one of the things that people send cases for consultation for is to that question of, is it too much to
Mm.
be benign, is it too much to be normal thymus, is even
Yeah.
in the lung adenocarcinoma versus reactive question, that's a very common question. It's
Yes.
just too much to be reactive.
Yeah.
I think that's where just a general, just knowing how much is acceptable is just a very, it's helpful to have a big database in your head
Yeah.
so you can compare to that and say this is just too much. The other
Drawing
thing
that
that,
line of normal to abnormal is sometimes the most challenging and important thing that we do.
yes, that's, yeah, absolutely right. The other thing I find helpful is these little, even at low mag, it looks like some of these things are microcystic.
Hmm.
These areas here, like this one here,
Yeah.
this. And I find, let's go to higher mag at those first. See, these little things I think are very helpful
Hmm.
when you're dealing with a thymoma or potentially a thymoma, is that you have these little cysts, and the moment I get a lot of microcysts, I start thinking of a type A
Yeah.
thymoma. And so the concept of a type A thymoma, let me just take it to higher mag and leave it here. The concept of a type A thymoma is that it's an epithelium predominant thymoma where the epithelial cells are either epithelioid, that means they look like epithelial cells, or they are spindly, meaning they mimic mesenchymal cells. But they are almost always, cytologically bland and do not contain too many TDT positive lymphocytes. So that's my definition. Matt, do you agree? Like how can we
Yeah.
say this best?
And that's something when I learned it, it just helped me so much with these because when I was first learning these, I don't know where I'd read it, but it was like, it really highlighted the spindle aspect of it, right? And I spent a lot of time like trying to look at the cells. Are they epithelioid or spindled? And I got really confused, and it was a real challenge. And then this concept of just thinking about it, about the number of the lymphocytes, it really helped make a lot more sense to me,
Yeah.
and that it's these lymphocyte poor areas that are really these type A that often have this spindled morphology. But
Yes. And I really find that sometimes it is hard. Let me take it to
yeah,
the highest mag. It's hard to really say whether they are spindly or not.
yeah,
In this field, this nucleus to me is round,
yeah,
but this nucleus is spindly.
yeah,
So that little distinction between when something is oval and when it's spindly is I think a little bit arbitrary.
Okay.
It can be easier at the extremes when everything is round. You say yes, this is epithelioid. When everything is spindly and it looks like a spindle cell tumor, fine. But
Sure.
many of these tumors are like at a gray zone where it's not really all that obvious.
Agree completely.
Maybe you go from one to the other. The other thing, Matt, I'd like to point out is in type A thymomas, compared to a carcinoma, let's say, compared to a carcinoma, these cells are very bland. And I've said
Yeah.
this many times before. I love the word bland because it is a way of saying not very atypical without saying benign. So you're not saying benign, you're just saying these cells don't look overtly malignant,
Mm-hmm.
right, Matt?
Yeah, I agree completely.
Yeah.
I think this is an interesting field here of showing how few of the thymocytes are actually in this field. And I
Yes.
think that this is a challenge I sometimes experience on core needle biopsy, right? Where
Right.
in a type A thymoma, when you're going to stain it with the TDT, you can often get very focal, if any, staining, right? Because you have so few of the
Yes.
thymocytes in it.
Correct. You want to explain to our audience, Matt, what
Sure.
thymocytes are?
Yeah, so these are immature T cells. So that's all these little kind of blue round dots all throughout.
Yes.
So I like to think of the thymus as like the T cell university. So all these thymocytes are going there to get their higher education and
Yeah.
remove their negative selection. But
Yes, actually, I was showing this thing to my wife yesterday, who's also a pathologist, and she was laughing at your T cell university thing. She really liked that a lot.
yeah,
T cell university.
yeah,
Yes, thymocytes. You know what I don't like about this term, Matt, is that you think of thymocytes as like thymic cells, and
yeah,
it makes you think like those are almost you think that those are the thymic epithelial cells, but
yeah,
actually it's the reverse, right?
yeah,
It's the thymic lymphocytes that are the thymocytes. So it's kind of a weird name to give. It just lymphocytes. I mean, that's what they are.
yeah.
The
No, it's
small
true, and I guess they're just immature. But that's an important point because the neoplastic cells in this are the epithelial
are
cells.
the epithelials. Oh, that's a good point to make now for people who are just starting off who might be watching this. Is a thymoma is essentially a neoplasm of epithelial cells. It's an
Yeah,
epithelial cell neoplasm, thymic epithelial cells, and the lymphocytes are kind of a variable feature. So in a type B1 or a B2, you might have a lot of lymphocytes, so many lymphocytes that might be the predominant feature. But in a type A, for example, or a B3, you have mostly epithelial cells, and that really is the neoplastic cell. The lymphocytes are just passengers. I don't know, Matt. Do you think that's a fair way to put it?
yeah, I think so as well.
Yeah. So, and thymic epithelial neoplasm. The other thing about A, and let's go to another field. So we take it to one of the maybe more microcysty looking areas and leave it there. One thing about type A thymomas is that they have been the subject of a lot of controversy over the years. One is because they're at the lowest end of the spectrum, right? So they're at the most cytologically bland end of the spectrum. And there has been talk in the old days, at least, about whether these were benign,
Mm.
whether there's such a thing as a benign thymoma. I think now there's pretty universal recognition that there's no such thing as a benign thymoma. All of them are malignant, even though the risk of recurrence is low in the range of 5 to 10%. And the risk of metastasis is even lower, much lower than that. Risk of death from a thymoma is relatively low. So they're not aggressive malignancies, but they are malignancies. Matt, any thoughts about like malignancy and thymoma?
I think the thing that I've seen is that they do have variable presentations, right? So many are benign and are treated with simple resection, but there are a subset of patients who will have metastasis, will have recurrence, and will unfortunately die of their disease. So there really is a spectrum of outcome for thymomas,
Yeah.
and that there, I know there's a big distinction with the different subtypes of WHO, but the outcomes aren't really that different between an
Yeah.
A versus a B3, and some of the studies have had variable outcomes and shown different things, I
Yeah.
think the general teaching is type A's do the best and type B3s do the worst, but that data is not perfect in any way.
Yeah. Yeah. Absolutely agree. I think some of the problem in this whole semantics is that when you have a tumor where the majority of tumors behave well, but a few tumors behave badly, do you call that benign or malignant? That is the problem really. Is like you have a tumor where there is a relatively low risk of aggressive behavior. And so benign is not really doesn't do justice to that term. You might say that even malignant doesn't do justice to that term, but it's more accurate than benign. You
Yeah.
know, if some of them can be, and I think it's very similar to, let's say, typical carcinoid of the lung.
Yeah.
Right? That you could say most of those have a benign behavior, but then some of them don't. They metastasize to lymph nodes. So I think it's better to encompass that, like be more aggressive in our terminology
Yeah.
than to call them benign and have them metastasize, down the line or recur.
That's a great point. And I think I'm glad you brought up carcinoid because I think that sometimes comes up in the differential for a type A thymoma because a lot of the peripheral carcinoids can look a little bit more spindled. So
Oh yeah, for
I
sure.
find that I'm often considering that in my differentials.
Very Rossetti, and yeah, for sure. These can be. Um, Anything else about the morphology here, type A thymomas, Matt, before we move on, that you would like to bring up?
No, I think that's great because we're going to do a type AB next, right?
Yes, we're going to do a type AB next. So let's see if I can pull that one up. So type A is, one thing I'd like to mention before we move on is that type A versus type B3 can be a problem.
Yeah.
Because B3 also lacks lymphocytes. And
Yeah.
there's no real immunohistochemical marker that is super helpful in that situation. Then you're dealing purely with morphology. Like, are these rounded polygonal cells? Are they more epithelioid looking versus a slightly more spindly, bland looking? So A versus B3 also has been over the years like a sort of area where the experts disagree.
Yeah. I find that one challenging as well. And I think I often rely a little bit on the nuclear features as well because it can be challenging to see the cell shape and everything, right? And so,
Yes, yeah, absolutely. Okay, so should we move to AB?
yeah, let's do it.
All right, so here is now, thank God there's a fibrous septum finally.
Yeah, there we go.
Otherwise, our book would be wrong. But what we find here is the classic fibrous septum. In fact, it's beautiful because the fibrous septum not only lobulates this tumor, but also divides it into a more lymphocyte poor area on the left and a lymphocyte rich area on the right. It's hard to tell at this mag, but it's slightly more blue looking on the right side.
Yeah.
And then I would like to point a couple of other things out because we said we would mention this, is that there's thymic tissue, benign thymic tissue at the edge of this here. In this fat, there's like little islands of benign thymic tissue. Can I look at that for a second, Matt?
Yeah, cool, please.
And then, of course, there are cysts, which are also
Yeah.
probably benign thymic cysts because they're outside the main tumor. But let's go to the thymic tissue for a second. So we're in the fat here. And then we are out here in the periphery, and you can see that you've got just a little island of lymphocytes and epithelium. I'm going to leave it here, Matt, for a second. This is atrophic thymic tissue with just mostly lymphocytes, a few epithelial cells here. It's hard to tell, but there's epithelial cells mixed in with this, and it's just laying here in the fat, actually admixed with fat. And this is what all that's left of the thymus. Do you agree, Matt, that this is benign thymus?
Yeah, no, agree. And you often see that on the outside, and there's little Hassel's corpuscle there.
Yeah, so you've got little Hassel's corpuscles that confirm that this. I find that this can be a little bit of a pitfall because if you fail to recognize that this is normal thymus, you might think that this is capsular invasion by Thymoma, and upstage it. But here's a beautiful Hassel's corpuscle here.
Definitely.
And then I'd like to go back and show you the cyst.
Yeah, so I think the cyst is a really important thing to highlight.
Yes, like here. So now here, this is the epithelium of the thymus has become cystic here. You can see the wall has a little fibroblastic appearance. Just benign, very bland epithelial cells and this by itself can form a mass. So you don't have to even have a thymoma. You can just have a pure thymic cyst causing an anterior mediastinal mass. And so this is a very common finding. Matt, anything else about these cysts that you'd like to?
I was just going to say they can often be seen in association with other lesions, with a thymoma or things like that. So there's just something to be aware of if all you're having is a thymic cyst. That make sure that explains the lesion.
Yeah, That's correct. All right. So time to go in. Hi, Mag.
Yeah, it's
So
cool.
let's go to this junction between this area and the, so as we go higher, we see more and more of this morphologic difference between the left side and the right side.
Hmm.
And let's keep the fibrous septum in the middle and
It's
go
like the
higher.
dividing line.
The dividing line. It's so beautiful because
Yeah.
there's a clear-cut dividing line here. So on the left-hand side, you have a lymphocyte poor type A component. And the right side, you have a lymphocyte rich type B component. But recall that because thymomas are a epithelial malignancy, the neoplastic cells even on the right are epithelial. So they're hard to see in here, but there are big cells. You can probably see them best at the this magnifier here, that when I go to a component here, you can see larger, a little bit more vesicular cells. So those are the neoplastic cells. So that's basically in a nutshell what an AB thymoma is. It has a clear-cut component of A and a clear-cut B. Let's see if I can show both components at high mag. So this is what the A component looks like. It's just mostly epithelial cells with relatively fewer um, lymphocytes. And if we did a TDT, there would be few TDT positive lymphocytes here. And here it's a clearly lymphocyte rich lesion with, I don't know, maybe we would call this B2 and if this were
Yeah.
the only component. But my understanding, Matt, is that if you have an AB thymoma, it really doesn't matter what the B component is. What do you think? How do you approach that? Do you care what the B is if there's an AB thymoma?
Not necessarily, but I think there's some people treat if there's a B3 slightly different. I think if I'm seeing a lot of B3 component, I think I would start to wonder, is it all B3?
I see.
Right? Just because sometimes the distinction between A and B3 can be challenging.
Yes, correct.
So I don't make a distinction between B1 and B2
B1 and B2. Yeah.
in the I don't know what your practice is.
Yeah, no, I think what I do is, or at least what I think I do is that when there's a B that's a B component, I try to say in the comment what kind of a B it is. Is it B1, B2, B3? Is it a mix of that? But I don't think so I bottom line it as an AB.
Yeah.
And then I describe the rest.
Yeah, I put in my microscopic description in our code words, I'll say there's clusters of epithelioid cells or, there's, rare cells, but I usually don't put B1 or B2.
Yeah.
I don't want to create confusion. It's confusing enough.
Yes, it's confusing enough as it is. Actually, this is one good, just going back to your concept, Matt, of trying to imagine what the core biopsy would look like of a lesion like this, that you could easily put a core biopsy in the A component and call it type A on the biopsy. And then you resect it and there's a B right next to it. So this is very important, I think, to point out that needle biopsy subtyping is not reliable because of this. Because when you resect it, you commonly see that another component comes out.
So how do you bottom line your core needle biopsies for thymomas?
I just say thymoma.
Yeah, me too.
Or I'll say epithelioid neoplasm consistent with thymoma, spindle cell neoplasm consistent with thymoma. Or if I'm on the edge, I might say epithelioid neoplasm favor thymoma or thymic epithelial neoplasm favor thymoma. So I'm always I'm trying to say that the most I'm willing to go on this is thymoma. Mm-hmm. I'm not going to do any more than that. And then I put the other stuff in the comment. Like if it all looks like it's A, I say it's all in this sample, it's all A, but subtyping is not reliable because of the heterogeneity on resections specimens. So I do defer it. What do you do, Matt? How do you?
I do the exact same thing, and I put a comment about how the subtyping is not reliable, and there's due to the known heterogeneity of these lesions.
Yeah. Okay. So we're completely on the same page there. So I think we're done with AB, Matt. Anything else?
I think the discussion of what is lymphocyte rich versus lymphocyte poor, like where do you where do you draw the? Because I think that's something sometimes people struggle with is, well, there's lymphocytes on both, but where do you draw your line between poor and rich?
I think that there is a grading system that the WHO.
Yeah.
I think grade is a weird word to use there because it's just a system for quantifying lymphocytes. They've set arbitrary borders. But what I like about that system is, if the lymphocytes are too numerous to count, that's not an A.
Yeah, it's
right.
True.
I like that part of it. If it's too numerous to count, like if I told you this might be an A, can you count the lymphocytes? And you go, no, I'm not going to count them. Then that's not an A.
Right.
If you say, well, yes, I can give you a count because it's still within the realm of,
Yeah.
countable, that might be an A. So
Yeah.
I think that's the, and there is a grading system, which I don't think we need to go into here.
No. I think it's an interesting
Yes.
concept of,
And of course it's arbitrary, right? At
yeah.
some level, how much you can count and cannot is arbitrary.
Maybe I'm a really good counter. I'm just really good at counting.
Yeah, I know some people who would
Yeah.
count this too.
I think a better question is would you be willing to count? Is not
Would
could
you
you
be willing?
count?
Yeah. Do you have other cases to sign out during the day, or would you rather count this all day long?
Yeah, exactly. 1, 2, 3. Yeah. But it's interesting if I think this is a place where image analysis could really help, right? Because image analysis can easily count the number of lymphocytes, right?
Yes.
And if it could do that, I think then making specific numbers, right, would be very easy, right? If you could
Yes.
automatically say in this field there's 10,000 lymphocytes or whatever,
True.
right?
I'm happy to cede all kinds of counting to image analysis.
Yeah, me too.
I don't want to count anything.
Yeah, that sounds great. Should we move
All
over
right,
to
so I'm going to stop sharing.
Yeah. Okay, can you see the screen there?
Yeah.
Perfect. Okay, so we're moving on through the spectrum of thymic lesions. And so I think this one has nice fibrous septae as well. They're not as thick as the other one, but I think they are there. And you can kind of see them kind of running through and surrounding these lobules of the
Yeah.
tumor.
Can I ask you a question here, Matt,
Yeah, sure,
about
please.
the low mag appearance?
Yeah.
So at the bottom left, it almost looks like this thing is in the fat.
Yeah, it is right there.
Is
So
it? So is that transcapsular spread, or what's going on there on the lower left?
Yeah, that is a bit of transcapsular spread here into the surrounding perithymic adipose tissue.
Yeah.
So that was a good
Wow.
pickup at low power. And I think that that's actually an important point is I spend a lot of time on low power with these things, and
Yeah.
I find that that can be really helpful. And that's an important aspect of outcome in these cases, right?
Yeah.
Is the spread and the T staging, right?
Yeah. Some people would say that's more important, right? Most people
I would
would
agree
say
with
that's
that.
more important than the subtyping.
I agree. And then I think the other thing that I appreciate at this low power is it kind of has a uniform appearance across it, in contrast to the AB thymoma that Sanjay showed in the previous one. It's a little bit more uniform in its amount of blue, and it does still look fairly blue. Maybe not as blue as you would see in a B1. And then the other thing that I'm picking up at this appearance is it's really uniform. I'm not seeing medullary areas or hints of Hassel's corpuscles. It's really just kind of the sea of blue, and that's kind of what I appreciate at this low power. I don't know if there's anything else you wanted to add to this.
Yeah, I would say, just my gestalt is, so if you're hinting at like that this is thymoma rather than thymus or thymic hyperplasia, it's just too much tissue,
Yeah, too much.
And the only thing I think that could mimic this is a thymic follicular hyperplasia, which then would have lymphoid follicles, germinal centers. So that's really defined by having lymphoid follicles and germinal centers. But I think this is immediately, like low mag, this is out of the realm of normal thymus. And because true thymic hyperplasia is essentially normal thymus, that's out of the differential too.
Yeah.
So once we find out at high mag that there are no lymphoid follicles, this is thymoma, and then we need to figure out what kind of thymoma.
Yeah, and I think the fibrous septae help as well, because you wouldn't expect to see those in a hyperplasia.
Yeah.
So let's zoom in a little bit higher. So I chose this case because it has pretty easily recognized. Oh, I'm sorry, it's just not focusing. There we go.
All right, Matt, you're never going to get me to count the lymphocytes in this one.
It's true. So we agree it's on lymphocyte rich. So we're in a B thymoma. And then I chose this one because I think the epithelial cells are actually pretty easy to identify in this one.
Yes.
I find in some cases it's actually kind of harder to see them. But this case I liked because you can kind of see them. And so I just wanted to talk a little bit about the distinction between the different types of B thymomas, where you go from B1 to B2 to B3.
Mm-hmm.
So B1 should really only be rare epithelial cells. and you shouldn't see clusters of it. And we use clusters of 3 or more. So here we have 1, 2, and then 3, and then there's another 4 down here. So this is a small cluster of epithelial cells surrounded by all these immature lymphocytes.
Yeah. Mm-hmm.
And so to me, this pushes me into at least a B2.
Yes.
And then the distinction between a B2 and a B3 is in a B3, you should start to see sheets of these cells without these intervening immature lymphocytes throughout. And so this case I would classify as B2. Would you agree with it, Sanjay?
I agree, Matt. I mean, I totally agree. I would call it B2. And I don't worry too much about B1, B2, like the distinction between B1, B2, because to me, that is sort of like the distinction between adenocarcinoma in situ and minimally invasive adenocarcinoma. It's completely in the eye of the beholder, makes no difference, and is probably like, you're probably likely to show it to the guy across the room or the lady across the room, across the hallway, and they'll call it something else. So I think that is, I don't think that's something to be too worried about. But I agree with you. Once I start seeing, like you said, once the epithelial cells are easily visible, that's probably not a B1.
Yeah.
And once there are sheets, that's probably not a B2. So that's how I'm totally in sync with your method.
And then I just wanted to highlight some of the nuclear features as well. Like the chromatin gets a little bit more vesicular look to it. Yeah. And you do have these kind of variable nucleoli, with some of them being a bit more prominent, which I think was a little bit different from the more bland looking nuclei that we saw in the type A areas.
In the A, yeah.
In the cases you show.
And yes, but also important to say, as these things get more round, the nucleoli start appearing, and you start getting into the realm of carcinoma, it's important to recognize that it's still very bland for a carcinoma. It's still very much in the thymoma cytology. Like you wouldn't look at this and say, oh, that's an obvious adenocarcinoma or squamous cell carcinoma. So that's really the difference between, let's say, a lymphoepithelial carcinoma and a thymoma, is that the cells are just not malignant looking.
I agree with you completely. And the WHO does outline that there's a thymoma with anaplasia, but the significance of that term has not really been well studied because it's fairly rare, and so the outcome of that is unclear. I don't know. Is that something you use in your practice, Sanjay?
Thymoma with anaplasia?
Yeah.
No, I probably don't look hard enough.
Yeah.
But those are the cases that truly need to go to a consultant, because those are so rare and difficult.
Definitely.
And a consultant probably will need to make a judgment call too, because there's no easy way to do it.
Yeah.
But you're right, Matt. Like occasionally you'll see greater degrees of atypia, and that really blurs the line between thymoma and thymic carcinoma.
Yeah, to me, an important distinction there is for thymic carcinoma, I'm expecting to see a desmoplastic stromal type invasion and look like an invasive carcinoma that I would call in any other area of the body.
Yes.
That's usually what pushes me to a thymic carcinoma is that really that invasion that.
Yes, actually, can I mention one thing, Matt? Like I find a rule of thumb easy for thymoma versus thymic carcinoma, relatively speaking. Okay, like if I look at a tumor and I go carcinoma, but thymus doesn't even come into the picture, right? I'm not thinking thymic. I'm just saying carcinoma. That's what a thymic carcinoma should look like. You should be thinking carcinoma, not thymic.
Yeah.
But if I look at a tissue and I say thymic first, like I don't know if this is thymus or thymic hyperplasia or thymoma, but it doesn't immediately strike you as malignant, then that's in the realm of a thymoma. In other words, your first reaction to a thymoma is thymic. Your first reaction to a carcinoma is thymic carcinoma is carcinoma. That's really how I think about it.
Yeah, I agree with that completely. And when you look at the cases, are you blinded to like where it is and the age and everything, or do you review the history first when you're looking at it?
I always, like for biopsies, I'm always blinded. I hate to know where it's from because it biases you fatally. For a resection, it's hard to be blinded because the thing, you'd see from the tray.
That comes out thymoma.
And you see thymic tissue at the edge, so it's very difficult to be blinded to that. But yes, biopsies, I like to be blinded. And I'll tell you, there are cases where it's difficult, no matter how much clinical information you have and how much is, especially on biopsies.
Yeah.
It's very difficult to make that call sometimes of whether something is thymoma or thymic carcinoma. But but that general rule helps. If if it looks thymic, then it's probably thymoma. If it looks like carcinoma anywhere else, it's probably carcinoma.
Yeah, I agree with you completely. And then I just wanted to show some of the stains for it. So we've talked a bit about the staining pattern of cytokeratin in these, and so
Oh, this is beautiful.
really, I know I love this this example. And so a lot of people describe this dense meshwork of staining that kind of connects all these thymic epithelial cells, and this is really what you're expecting to see. And so to me, one of the most important stains on especially small biopsies is a cytokeratin, because really what I'm most worried about ruling out is a hematolymphoid neoplasm in these, because that shouldn't come to resection. That's going to get chemotherapy, right? And so
Yes.
so if I see this dense meshwork of staining of keratin, that's really helpful for me to say that this is likely a thymic lesion with all these immature lymphocytes around it.
Yeah, that's a great point. What I'll mention to you, Matt, is the power of Twitter here,
Yeah.
because I have actually never seen a thymoma in the mediastinum where there was any cytokeratin staining. Although theoretically that could happen, right? You could have a thymoma, a lymphoma that's invading into the or arising in thymic tissue. So you might have normal thymic tissue showing some. So it's theoretically
Yeah.
possible, but I've never actually seen that in practice. But
Yeah.
I did see one case on Twitter posted by Tristan Rutland,
Yeah. He's got great cases.
really great cases.
Yeah.
And he posted a lymphoma with a little bit of thymic tissue at the edge.
Oh my God.
And I'm like, oh my God, this is my worst nightmare,
Yeah.
to see cytokeratin staining. But in practice, I've just never seen it. So I'm totally 100% in agreement with you.
Yeah.
Cytokeratin is like just a pan cytokeratin is a
Yeah.
lifesaver in small biopsies.
And then the only other stain here is here's the TDT, which highlights all these immature lymphocytes all throughout
Yes.
the case. And so and these are my two go-to stains in thymic lesions, is a keratin and a TDT.
Mine too. I'll point out that sometimes you'll have a very lymphocyte rich background.
Mm-hmm.
You can even sometimes have in a type A thymoma, a lymphocyte rich background, but when you do the TDT, they're not TDT positive.
Yeah.
So that still doesn't qualify for a B area, because what you need is TDT positive lymphocytes.
Exactly.
And not all lymphocytes in thymuses are TDT positive.
That's a great point. Yeah, so I think we've covered both the A and the B type thymomas.
Yeah.
Is there, I guess, some of the take-home points I'd really like to highlight is that these distinctions can be challenging and are at some points kind of arbitrary, and they're important, but the most important things for these is likely the staging for these. And so that's, and realize that there's an overlap between some of these, and it can be hard to definitively classify. So to not lose too much sleep over,
Yes.
is this a B1, B2, or, because the distinction is not really that important. What is most important is making the diagnosis of a thymic epithelial lesion, excluding lymphoproliferative disorders, and accurately staging them.
Yes. Great take-home points. I agree with all of that, especially the exclusion of lymphoma in a small biopsy, because that so dramatically changes therapy. And also staging, Matt, I'll ask you what you think is most important. But the two things I see most commonly is it goes past the capsule clearly into the extracapsular fat. That's one thing. And the other thing is some invasion of the lung parenchyma, that I see that sometimes too. Anything else in the staging that you see microscopically, Matt, that would change the stage? Am I missing anything?
Well, I think a lot of it depends on really the specimen, the surgeon. So that's another important thing I find is I think these are all cases that I really read the operative note,
Yes.
and really, did they take some of the pleura, where was it adhered to? And so, and I think that's another plug, is that when you're grossing the specimens, it's really important to understand what is a true margin, what did the surgeon resect, and in cases where it's not clear, it's really important to talk to the surgeon. To have them clarify that, because these margins can be challenging to assess, and they're often quite close, I find, for thymic lesions, because there's not a lot of tissue around there for them to take margins on,
right. Before we end, Matt, I'll make a plug right on the video here. If anybody who is listening wants to join us in a future episode of this, reach out to either one of us. On Twitter is the easiest way. Reach out to one of us and say you're interested, and maybe we can arrange a call where you are in on the session and we can have a chat with you. Right, Matt?
Yeah, that sounds like a great plan.
Yeah. Okay.
Yeah. Well, thanks, and hope everyone has a great day and stays safe out there.
Thank you. Take care.
Bye.